Hi guys, for this week's case I've got a really nice simple ortho case. Literally this case took me 5 visits from start to finish, right? And you'll see how it went. So let's get straight into it. Okay, so let's get right into it. Let's find the patient we're looking for and go to the pre-ops. Cool. So this is where we started off from, okay? And you can see the main reason the patient doesn't like her upper and lower teeth, so we'll look at both of those. And these are the pre-ops. So I'll do a full case assessment, like a full ortho diagnosis on these cases, but just for the sake of keeping your attention, I'm just going to go through it quickly. We've got half unit class 2 canine relationship here. This tooth is a little bit proclined, but all the others are relatively upright or retroclined a little bit, so that'll be useful a little bit later on. We can see the gingival margins are all over the place. And on the other side we've got class 1 canine relationship, which is great. So here we can see the main thing she's come in for, but we'll go over this photo in a little bit more detail in a minute. These are the bottom teeth, similar kind of thing, just a bit of tooth wear and a bit of misalignment. The lower arch is a lot easier in relation to the top arch. Okay, and these are the occlusals. So if we just quickly skim to the actual photos, then we can go through the whole case. Okay, great. So from a cosmetic point of view, there's a few things that could be improved here. First of all, we've got the misalignment of the teeth, and yeah, to treat this case, there's probably about 20 different ways of doing it, but I'm just going to show you the way that I did it, which was ortho first and then bonding afterwards. So first of all, we need to make the patient aware that there's a couple of other things going on, i.e. there's all this tooth wear, so you know the teeth should be a bit longer than they are. Okay, so we've got tooth wear here. The reason we need to make the patient aware at this stage is because once the teeth are straight, they're still not going to look great because of all this tooth wear. It's going to become a lot more apparent after the teeth are straight. We've got this composite filling, which she doesn't really like, and we've got all this discoloration at the neck of the tooth, which she doesn't like as well. So she's aware of those little things there. The gingival margins could be much more improved, so if we get it symmetrical with this side, it'll be a lot nicer, and this lateral here can be improved as well. The whole thing could be brightened up. I would also draw her attention to the recession here, and any other clinical findings that you find on your examination and radiographs and all that. Okay, so let's look at bracket positioning, because that is key in a case where you've got a little bit of anterior tooth wear. So first thing that I do is I'll imagine what the tooth would look like if it was unworn. Okay, so I think the incisal edge should be somewhere around there. It's not a million miles away. And then do the same thing for every other tooth which has tooth wear. Okay, so I think that's not a million miles away. That's about right. So from here, now we can judge where our midpoint of the tooth is. So what I'm looking at is the midpoint between here and here. All right, so, and then also judging the long axis. So let's just quickly draw the long axis of all these teeth in first. Okay, so something like that, there, and there. Actually, this one should be there. Okay, and then we can draw the midpoint. So midpoint, remember, is from here, not the bottom edge here. It's down here, our new bottom edge. So that will be there. This will probably be here somewhere, and something like that. So I do this all in my mind's eye, and you kind of know that the incisal, the bracket positioning will be lower, more incisal on this tooth than it will on this tooth. So it will look really odd, so just be prepared for that. And the only other thing I'm going to visualize is our gingival margin, and it's really the height that we're looking for. So we want the height of that one to be there, and ideally, although it's unlikely we're going to get it, is we want that lifted up as well. Remember, if this tooth is the gingival margin's lifted up, then the incisal edge is going to get lifted up as well. This patient's not showing loads of gum when she smiles. So it's not really that important in this case on here. We're going to leave this alone, not going to do anything there, and we're planning to do all the composite work at the end of treatment anyway. So on the lower occlusal, we can see that there's very little to do in terms of relief of crowding. So it's really just these two teeth here, and that's going to get done in a matter of weeks. It's hardly going to take any time at all. On the upper occlusal, we can see a couple of things. First of all, we can see the tooth wear. There we can see the tooth wear in there as well. Also, we can see that this tooth is actually very retroclined, so we've got loads of room to bring that forward. We can bring this forward as well, so it's kind of in line here and here. And this tooth, we can bring it forward a fraction. So in all, we've got 3 potential teeth that we can tip forward. This tooth keep where it is, and if we do that, we're going to minimize the amount of IPR. So I think this was 0 IPR in this case, and we're not going to end up with teeth which are overly proclined that we need to correct in the end. Okay, so let's go back into her clinical photos and I'll show you what we did. This was her bond up appointment, so we're using 3M Gemini brackets, right? I use these brackets for like 90% of the treatment that I do. They're really good quality brackets. You want good quality ceramic brackets. Composite brackets and any of the cheap brackets are really not worth it because you can't get the precision at the end of treatment with those, because the ceramic brackets won't deform, whereas the lesser brackets, they will start deforming and breaking during the middle of your treatment. So anyway, we got the brackets on in the places that I described before, and we've gone straight into an 18 night eye wire. Because I could comfortably get that in, and we just left it there for 6 weeks. So after 6 weeks, we can see that things have straightened up a lot. The gingival margins are a lot better. This one's still a little bit low, but it doesn't really matter too much. I've jumped into a 20/20 wire now. We've got this little gap developing here, and remember, when we're unwrapping 2 teeth, we can sometimes get a black triangle, but we were quite lucky in that this gap was pretty uniform all the way across. So all I did was power chain from canine to canine on top of the wire, and just to retract, pull everything back and close this tiny little gap. Again, at the lower arch, we've got a 20/20 wire. At this stage, the patient was really happy with the way that things are progressing. So looking at it from the side, the inclination of these teeth is a lot better now. Okay, and occlusally, the lower arch looks like it's done, and the top arch isn't a million miles away either. So after another, I think it was 4 to 6 weeks, something like that, we actually did the debond, and this is at the appointment of the debond. So we can see that everything looks a lot straighter, but it still looks rubbish here, right? The bottom edge of this. I think there's still composite from the bond up on the teeth here. So what we normally do is I'll put the fixed retainer on behind the teeth, take the brace off, and do the composite bonding all in one sitting if I can. And it was pretty straightforward how to do that. I'll show you the photos now. So braces off, it's a bit more cleaned up now. Separate the teeth. This isn't going to go all the way up to the gum, because we know we've got the retainer behind the teeth. But these incisal edges are all that you really need to separate. So it was a case of sandblasting, etch, getting rid of the old composite. We went all the way up on this tooth, and then do the composite as you would normally. Obviously, we're taking the shade way before we started all of this. And this is how I did it. I overbuilt everything. We've got a little defect here, right? So it's really important to use good magnification when you're doing this to see these little defects. I just filled it up with flow with a separating strip in the middle, and that was sorted out. And then we just polished them. You just take your time, polish it really, really well. That's really important. And don't be too disheartened if the composite is really obvious, because the teeth are dehydrated, your colour match. You got to just keep the faith with your colour match right at the beginning. And the retainer is 2 to 2 at the top, because I find that the 3s tend to debond, especially if you've got a heavy occlusion on them. I will sometimes bond the 3s in the upper arch if they've got a reduced overbite and I know that there's no occlusion on those. In the lower arch, I'll always do 3 to 3. Okay, so this is the end result. So a couple of, I think it was a week later, we called her in to give her her removable retainer, and you know, generally everything looks amazing. She's really happy with the result, and you can see that the teeth have merged in with the composite a lot better at this stage. And this is the lower arch. In the lower arch we just did composite on the 2 centrals there. So if we look at the end result here, I mean the composite I'm really happy with. The position of these 3 teeth I'm really happy with. This tooth could be improved a little bit if we're being really picky. The problem is, the root is up here and the incisal tip is here, so the root is a little bit more palatal. To sort this tooth out properly, what we need to do is look at a torquing movement, which you use rectangular wires, usually stainless steel, to add a little bit of torque, and we want to move the root more buccal. So we want buccal root torque, and then this tooth will look a lot more straight in that instance. The downside is when you start doing that, the gingival margin can creep up as well. So she was happy with it, and that's all that matters. So you know, that's a minor little detail. Thanks for watching. I hope you found the video useful. If you've got any questions or comments, I'd love to hear them. Please give my Facebook page a like, and give this video a like and share it out to all your friends. Take care.